We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together. Welcome to the Healthcare Revolution podcast. Today I have with me Dr. Bowden, who is an absolute expert in spinal biomechanics. He has his PhD in mechanical engineering, and he specializes in medical device creation. And I believe it's the future of medicine, where we can use devices that can help us make good decisions in movement, where it can give us information on when is too much for our bodies to handle before we go into injury. So really excited to talk about this topic today. Welcome to the podcast, Dr. Bowden.
Thank you. It's great to be here. Appreciate the invitation.
If I say anything that's just like out of the ordinary or wrong, please correct me, because the research world, I love it and I appreciate what you do. The language is hard to keep up with sometimes.
Oh, it's awesome. Really appreciate it. And frankly, I'll try to speak to the right, level here. I love talking with people about this. I'm passionate about kind of where the future is going. I feel like we're at this kind of inflection point where technology can start really doing some interesting things for us.
Absolutely. And I love this idea of this device that you've created at BYU as a professor and all your research students. Imagine, if you're listening to this, imagine a device that could measure if you were out working in your yard. It could give you warning signals on if your muscles have fatigued to a certain level to where you're at risk for injury, right? Or you're lifting a weight that your body is about to fail muscularly, right? Where you could be at risk for injury. Like, what if the future could tell us that? I think about like Iron Man, right? And it has the battery signal that he can see. It's like, you're depleted on energy. Don't do any crazy punches, right? Like, that is essentially where we're going with these devices and what you've created, right? And it's so cool. You've created, I think, 1,100 or so of these, and they're not ready for the public yet, but you're testing it. It's giving you good data, all that. Tell us just a little bit of background of why this started and where it's developing.
Like most things that are really cool, it started a long time ago and was really boring. Probably 12 or 13 years ago, another professor in our department, David Fullwood, and I were talking about, we had this idea for incorporating these cool, they're called nanoparticles. They're very tiny pieces of nickel and carbon, and what could we do with them? We were looking at different types of ways we could measure things, and they got embedded inside of some silicone and turned into this stretch sensor. This stretch sensor that could be made really cheap and could be made to give you some context, right? So normal ways we have as engineers to measure stretch, they are called strain gauges. We put them on bridges and we put them on all kinds of normal things that we want to know if they're going to break or something. And they can stretch about 5%. So if it starts an inch long, by the time it gets to 1.05 inches, it breaks. So it's not very good for measuring biological things like skin and tissue.
Yeah, because they
skin
stretches a lot. Significantly more.
They stretch almost double. So if that little stretch sensor is an inch, it needs to get to 2 inches. But this new technology we were playing with could do that. It could double its length and measure that accurately. And so we started figuring out how to develop these, invented them, got patent on it, and kind of figured out how do we start using it. So we spent a long time figuring out the basic science of that. And then we got to do the fun part, which is where we get to put it on the body and measure things. And we've used it to measure how your knees move. We're using it to measure how the spine moves. We're using it to measure how.
And your special interest is in spinal biomechanics, correct?
That's my forte. But we're using these to measure like how babies kick in the stomach. We're using them to measure how people swallow down their neck for dysphagia. We're trying to measure all different ways the body moves. But my passion is the spine. And so for the last 6 years, we've been using these sensors to measure how the skin of your back moves. And that seems a little weird because why did we care about the skin? But if the skin is moving, it's because something underneath it is moving. And so we actually, looked at how does that represent how the actual vertebrae are moving. And it turns out it correlates really, really well. And because of that, we can measure, based on something that sits on your skin, what's happening with all the vertebrae in your spine. And as a result of that, we can start to see what's actually going on. And we can do some of the things you were talking about. We can tell whether you're moving differently, your spine is moving differently because you're tired, because all the muscles in your spine have gotten tired. I'm not just a person who researches the spine. I have bad things in my spine, right? So my L4, L5 disc is shot.
So you're doing this because you're selfish, huh? You just
well, see, the thing is, it kind of worked out. I picked this before my spine was bad, right?
So you're already knowing all these things, right? And talk us about, before you go into the story, talk us about why is this needed? What is the impact globally and nationally on back pain?
Yeah. So, back pain is startlingly pervasive, right? So the statistics say that, 3 out of 10 adults you run into on the street have had a back pain episode in the last 3 months. That's a lot of
Just
people.
in the last 3 months.
That's in the last 3 months. That's, 3 out of 10 people you run into have had back pain in the last 3 months. And
what's
if you're an
healthcare
adult,
costs on all this?
It's insane. So
and it keeps growing, right?
$230 billion a year that we're spending on. And that's mostly just looking at the medical care costs, the direct ones, not what it's doing to people.
Taking people out of work.
That's
and
right.
All the other things
the
that are limited.
The impact on the economy is 40% of sick days are a result of back pain. It's crazy. And within that group, so most of us have a transient episode of low back pain, but 1 out of 5 of us will get chronic low back pain where it keeps coming back over and over again. And the average length of that is 7 years. 7 years that you're having this chronic low back pain. That's an instantaneous, like right now you ask, how long have you had low back pain? And you average that 7 years that people have had that. Some people will never get rid of it. We have some great ways to help people with low back pain. But each of those ways, the statistics say, only work for about 30% of the people that use them. In advance, we don't know which 30% it's going to be. So if you get connected with the right treatment for you, it's going to work great. But that's a mystery right now. We don't have a great way to know whether we should be sending you to the physical therapist or to the surgeon, to the pain psychologist, or whether we should be giving you a medication. We don't know what's the best way to treat you.
Back pain is multifactorial. There's so many things that influence back pain, and I have treated low back pain probably more than anything else in my clinic. And the better I get at it, the more I realize how complicated it really is. I used to think it was just like one factor. It's just the way you move. You're limited in mobility here, like motion, and you're limited in strength here, right? That's all I was focusing on at first. And then I realized how much sleep was having the impact, how much nutrition, how much psychology, how much like negative beliefs from the past. Like there, even socioeconomic status, like stress at work. Like there's so many things that play a role in back pain, and it's become very complicated. And now I treat back pain very differently. There has to be, since there's so many factors, there has to be multiple people involved to know who is going to be the best person for this specific case.
Yeah, exactly. And the thing that ties that all together is all of the things you just talked about affect the way we move. And if we get down to that, That's what's exciting for me as a mechanical engineer, to realize that maybe one of the key missing pieces is we're not understanding the connection between how we move and how that reflects that entire paradigm of things, from injury to damage to degeneration to how we're feeling, to all the pieces that kind of tie us together. And that's exciting for me, that movement is really this window into our health. And right now, you are a smart guy and a good physical therapist, so you're going to know when you see a patient, the way they move, things about them that you can tell just by the way they move. But explaining those to somebody else, to a different physical therapist, quantifying them and using them to diagnose what's going on, that's a little trickier. And that's where we think technology can really put us.
Yeah, imagine if like this device that you're creating, like we have a term called remote therapeutic monitoring now, where we track things. Say I give 5 exercises to you. You come in for back pain. I give you 5 exercises. The app can track how often you're doing them. You can put in there what types. Did you have pain with it? Was it easy? Was it hard? And then I can change things remotely to influence that, right? And how cool would it be? When I see people in the clinic, I watch them move, but I can't see their job. I can facilitate their job. But if I could monitor them all day long and I just got all this compiled data and that was presented to me, I can make so much better decisions. Sometimes I'm like, I wish I could just go to work with you. I wish I could just follow you all around all day long as a therapist, because I would know most likely what is going on throughout your day. Right? And it would give me a lot better picture. And sometimes I'm like, can I just jump in your body and drive for a minute? Like, I just want to feel it. And I want to know what's going on in your head so then I can know how to fix it, right? But this is a great tool that we could use as clinicians to help understand and inform and educate patients better, to be able to move differently during different circumstances in their life.
That's exactly where the technology is going. Not just our technology, but we're actually reaching this inflection point in our society right now. There's 2 competing pieces, 2 wonderfully accelerating pieces, I should say. One of them is we're getting more and more sensors, wearable sensors that can be attached to our body, collect data points that we didn't know we could ever get before. The other one is the rise of AI and machine learning, which, we can talk about kind of the philosophical ramifications of that later. But for the now, it can process massive amounts of data that would otherwise be very difficult for us to put a handle on. And with those 2 technologies going so quickly, merging those together allows us to do the kind of things that you're talking about. And we're so excited about that. We feel like we're living on the threshold right now. Within the next few years, you're going to have so much data as a clinician that it's just going to be a different world. Getting prepared for this massive amount of data that's about to come to you, to be able to help you to make those kind of informed clinical decisions.
So we're talking about the future of medicine and these medical devices to give us good information. Tell us about those and how these next couple of years are going to influence everything.
Yeah, so within the next few years, you've got so many these technologies kind of converging, right? And it's going to provide you more information as a clinician than you have ever had. So you're going to be at this precipice where you're going to be bombarded with data from wearables interpreted by AI that's going to give you kind of this instantaneous look inside the patient in a way that just allows you to experience, kind of see what they're experiencing, and then use it to diagnose and treat.
I'm thinking about this as like an Iron Man suit, right? Like I have the Iron Man suits telling me how you move. And it's giving me all this information to say, yep, you did a little too much right here. Oh, you started to move through your spine way too much with unloading sod on your yard. Like, you were playing football for way too long. You could see how your energy was depleted here. right? I love the Whoop watches because they're measuring heart rate variability, and they're giving people ideas of where their battery life is, right? Like, you have only recovered 20% from yesterday. Would this be a good day to go out and run a marathon? Probably not, right? But this data that you are creating is absolutely incredible for helping people decrease the $280 billion that we're wasting in healthcare for spine, for low back pain, right? And it's incredible. Like, this stuff is so cool.
Yeah. And, there's two pieces of this. One of them is really exciting, like we've been talking about from the clinician perspective, and it's fantastic. The other one is self-efficacy, that you can have your own dashboard into your spine health that you can look at and say, oh, maybe I should make better choices today.
Yeah.
I mean, that's...
Yeah, and I love that for the patient, right? It's like, the question is like, how is this helpful for the patient? You just said, it's a dashboard for you to make good decisions throughout the day if you're going to go lift 300 pounds, right? And it's giving you data to say, to make choices that are going to influence your life.
Yeah, and imagine that you could track personally in your life what were maybe the biomechanical triggers that happened. Like, I did this, and the next day, X happened. Well, and then that happened again. And all of a sudden, what's going on in your life that's triggering these enhanced pain or a good day. Like, what are the things that are causing you to have good and bad days with your pain, with your body, with the way that you're moving? What an insight that could be to us to understand better those biopsychosocial, the biological, the body, how it's moving, what's wrong with it, how our relationships, how our psychological well-being, how they all kind of mesh together to give us kind of this map as to
ultimately it's recognizing patterns, right? So the direct correlation between dissatisfaction with work and back pain, right? So if people are constantly dissatisfied in their career, it's more likely they'll have back pain. Or if they have back pain, there may be an association there, right? But the app says, well, every time you go into work, you have back pain. That might help people identify your dissatisfaction in work is potential cause of your low back pain. How can we change that, right?
And it also might help us to see that it's not as bad as we think. We tend to remember the things that we feel bad, that make us feel bad, right? And we might go back through that history and say, well, 8 days out of 10, I actually am fine. But it's just those two. And what happened those days? Mm-hmm. Where's the pattern? And maybe that helps us make
those
good choices.
2 days we were making big strategies for a company and I had a lot of load, right? And I don't want to diminish the mechanical or like the other psychological or emotional components at all. We're only talking about one factor here. But ultimately, it helps you recognize patterns to make better decisions.
Which is exactly what AI is really good for. So getting that data, having a tool to interpret it, real time, massive amounts of data. And what's interesting to me is, I love the technology we're working on, but it's also really cool to see where the future is going, which is not just one cool technology. It's actually multiple sensors of multiple types, all feeding data into the same kind of interpretation AI that can actually give us this kind of complete picture of what's going on with us. It's really cool stuff.
That's awesome. So spill the beans on what this looks like. I know it's developed. Talk to us simply about how did it first develop? Give us a visual of what these pads look like and what potentially what this looks like in the future.
Yeah, so the version we've got now is one that we've actually used in our clinical study. We've actually had this on 650 different people, some that are what we call our healthy controls, right? So normal people that don't have any back pain. And then 500 people with different kinds of chronic low back pain.
Why would you measure someone that doesn't have low back pain?
Because we need a comparison group. Yeah. And what's really interesting to us
how does healthy people move and how do people with low back pain move?
What's the difference? We need some way to look at them. What's interesting to us is that looking at healthy people, with a small fraction of them, we see patterns that maybe they're about to transition to becoming some of our chronic low back pain folks, which is interesting. But within those chronic low back pain folks, there's different types of ways that people move, different kind of strategies people to move when they have pain that actually might reflect different things. But essentially, we've got this group of people that we've looked at, that we've measured. But, you'd ask kind of what does this look like? How do we get this data, and what does that look like? So the initial version we had here is actually attached to the back via an adhesive. So it's made out of the same stuff that kinesiology tape is, that we commonly use.
KT tape is, yeah.
And
so it's almost like, is it separate ones where you're doing like 10 of them, or is it just one strip of KT tape?
It's one strip, and right now it's put on by a clinician, right?
Okay.
So the clinician measures where your L5 spinous process is and basically attaches it right there based on how that sits on your body. They do it in the clinic, so it takes just a couple of minutes to put on this essentially piece of tape that's got all the sensors embedded in it. It's connected via Bluetooth, all these sensors,
so cool,
to an app on your phone.
And super cheap, right? Like you guys designed it so it's not
$100,000. Each of these sensors is about 10 cents worth of material. The whole thing together is about $8 worth of material.
That's so wild. I mean, that's so crucial, because if we're going to use this throughout society, we got to make it cost effective. If you make something that, this costs, $50,000, how much are we going to use it? But you're talking $10.
Yeah, exactly. So, and of course, at some point someone's going to have to turn it into a product. It'll probably cost more than that. But in terms of material,
a couple hundred, I'm sure, at least.
In terms of material, like, it's very inexpensive. You put this on the body, and then we have them move. We've got 13 or 14 different movements that we have them do, and they do them several times while we're recording their data using this app on their phone. And with that data, which takes about 15 minutes, so 15 minutes worth of data in the clinic, then we take that piece of tape back off, and that data is being sent from the app to the cloud, where it's being automatically interpreted by a machine learning algorithm, by AI, and sent right back to you real time on your phone, where you're able to see.
What kind of data is it giving the patient, or who's got this on?
Yeah, so right now it's not on patients, it's on research subjects. So we're not actually giving them anything. But
okay. So in the future, what do you hope to do?
In the future, it's going to send them back essentially this kind of real-time status update as to how they're moving and how that movement correlates with other people who have had successful solutions for their low back pain, for their chronic low back pain.
Essentially, it's going to give them advice like, your battery's getting a little low, or like
so there's two ways.
Recommended to slow down a little bit, or don't do that movement as much, or you're at risk for injury. Is that kind of stuff we're talking about?
No, not yet. So let me talk about two ways. One of them is kind of like that, but the one I'm talking about right now is really just maybe more advice for your healthcare, right? So the idea would be, I talked about, we've got this conundrum, right? We've got great treatments and we don't know who to send you to. What we can do is we can figure out among the people who have had chronic low back pain that's been successfully treated, where do you fall? Maybe you behave like somebody who should go in for physical therapy, and so a physical therapist should be quarterback on your treatment. And that's where you should go, and they should be guiding everything you're doing right now because they're going to have the most success. Or maybe you're behaving like somebody that the way you move reflects that you really need some surgery. And that's really the only thing that's going to fix this. And we should be connecting you with a really good surgeon so that they can be fixed. Or maybe it helps you know you should be visiting with a pain psychologist, because physical therapy or surgery are not going to fix this. And you need to get some help with some things that are going wrong in the pathways from your brain.
What are some things that the device is measuring to determine Let's just talk about between a surgeon and a psychologist. How does it measure that?
Yeah, that's really cool. But it turns out, there's this thing called fear avoidance, right?
Mm-hmm.
That you're pretty familiar with, right?
Yeah.
That at some point in the past we've had an experience that's triggered pain. And even though the thing that has triggered pain maybe has even resolved, our body has learned to move a different way to avoid that thing that caused us pain. The problem is we keep moving that different way for too long,
Yeah.
and the rest of our body suffers, and we start to get pain in places that have no connection to the thing that triggered it the first time. And we've got to change the way we move, but we have to resolve that in our brain. And sometimes the other thing that can happen is we can centralize pain, where we're triggered by some pain. Like in the past, something got damaged and injured, but now the thing is gone, but the nerves are still firing, still sending signals to our brain.
Yeah.
It's almost like a phantom limb pain, right? So, you have a trauma and you lose a limb, people who lose a limb can still feel pain in the limb that's not there anymore.
Yeah, I can attest to that. I've cut off a finger, and I for about a year and a half, I always felt the tip of the finger, and it actually hurt really bad, and it was the phantom limb pain. So yeah, I totally understand, and all this really resonates with me because we talk about pain, fear, like fear avoidance. Fear avoidance meaning defined as, I remember that motion caused me pain, therefore I will not go into that motion. And a lot of times it wasn't the motion that caused the pain. There was other things in life that depleted your energy enough and your psychological awareness enough. That was just the needle that broke the camel's back, like that was the last straw before you got hurt. But the brain remembers that, and it begins to avoid those certain movements. So, for instance, if someone got hurt picking up something with a hip hinge, if that's how they got hurt, they move differently by squatting more rather than hip hinging. So I love how that device is measuring, oh, you're actually not leaning forward at all and using your glute muscles. You're literally using your quads to squat. Therefore, we know this is more of a psychological component than a mechanical, component. That's where you would do better with a psychologist than a physical therapist.
And see, that's the cool part about our data, is our data from these 650 people that we've got, along with collecting their movement data, we collected this battery of information about about their psychosocial state and whether they have anxiety and sleep deprivation. And we collected data on the way that they move. With a physical exam, we collected all kinds of data from these folks. And so, including MRI data from them. And so now with all that data, we're actually able to figure out what are these groups. And there's a term we use, it's phenotypes, but essentially what are these kind of natural breakdowns, clusters of ways that people move, and do those correlate to...
So essentially you got back pain and you got different file drawers. You're like, this is the category you fall into based on these files, these categories within it, right? And then here's another drawer. Here's what this defines. So you essentially have different file drawers for these different types of people, and you say you're going to do best with this, or you're going to do best with these options.
Yeah, and what was really cool from our perspective was we didn't start out with an idea that we were looking for this group, we're looking if there's commonalities.
Yeah.
We took the movement from all 650 people, and we just said, are there natural groupings in that? We're not going to pay any attention to what their pain status is or what their anxiety status is or anything. We're just going to look for natural groupings of way that people move. And then we're going to look at the people that fell in those groupings. And it turned out that it naturally fell out that almost all of our controls fell in one grouping. There was another grouping that was of people that basically had low levels of pain, low levels of disability. So they were pretty functional, but they still had this chronic low back pain, and they kind of moved in one category. Then there was another one for ones who had large amounts of pain and disability, and they kind of moved one way. And then there were folks who had large amounts of pain, but also large amounts of psychosocial challenges, right? Their anxiety was high, their sleep was poor, their depression was high, and that was a natural group too. So we found those groups without having to kind of preconceive how they might fit together.
So wild, yeah. I remember we talked about in rounds one morning, we talked about how cultural background or socioeconomic status can directly influence perception of pain. And we realized through the studies that we are looking at. Do you remember this rounds? So yeah, jump in if you feel like I am not summarizing it good. But the culture that had the most the highest perception of pain was Hispanic people, because they had the lowest locus of control, which means like they don't have control over their life. They don't feel like they can influence a lot in their world, right? And the interesting thing is Poland was the highest perceived or the lowest perceived pain, but yet the highest Christianity level and the highest locus of control. And we realized that those Christian people had the most control over their lives, therefore they had the least amount of perceived pain. And I thought that was just so incredible to understand that. The more control you feel over your life, the less pain you actually have. What are your thoughts on that?
Let me share a different study that I think is really interesting to me. One of the things that kind of talks to this same point. There's been a number of studies that have looked at VR, right? And how virtual reality, and how can that be used as a treatment modality for folks with chronic back pain?
Yeah.
And what was interesting was when you put people, so this study was designed so that you had like essentially putting on a VR headset that just had like a static image in it. You had a VR headset that you just went on a nice walk somewhere. You had a VR arm of this study where you put on this, and it was an immersive environment where you did specific kind of relaxation things, and one that you did like different types of movements that kind of gave you physical therapy, even though you were, in this immersive environment. And what was really interesting was that the control subjects who just for certain, like the immersive, let's put you in this the physical therapy inside VR, it definitely worked for reducing pain. What was really interesting was it was no better than the group that looked at the static image. And which also was much better. Like that was an effective treatment modality. What was interesting was that it was the process of having your brain taken away to a different environment that actually provoked the change. So while you were in this immersive environment, you realized, hey, I'm no longer hurting. Like my brain's thinking about something else. I'm distracted from the pain. That was really cool. There was nothing in here that should have done that, but it did. And once you realize your brain can do that, it can change, then you realize you have more control over your pain outside of that immersive environment. So you can start to exert control over something that you previously believed you had no control over.
Yeah.
That locus of control you're talking about, it can be adaptable. We can teach it. And that's really cool to me.
Yeah. And I did a VO2 max test the other day, which is pretty much like the gold standard for measuring your fitness level. And it was an incredible test to understand how I do under stress, like physical stress, because what would happen is he would increase the speed of the treadmill and the incline of the treadmill. And there were certain thresholds he was looking for. And at each level, he was looking for me to plateau my heart rate. So we'd rise it up, make it faster, and make it harder. And then my heart rate would go up, and then essentially it would normalize. And what was really incredible to me as I learned this, I've spent my whole life in injuries, and I've broken over 30 bones and just been in an immense amount of pain. And I have learned how to suppress or essentially turn off pain signals because I've done it so much. And I've realized how much the brain has control over pain. And I've learned how to essentially take my 8 out of 10 pain down to like a 2, based off of breathing technique, based off of self-regulation. So on this VO2 max test is what I'd see is my heart rate would jump up, and then I would self-regulate and bring it back down. And then the next level, it would jump up past the threshold. And instead of just normalizing at that new threshold, it would actually come back down and then normalize. So it was showing me that I was really good at regulating, like noting that the stress level was higher, but then I could bring it right back down. And I didn't bring it back down to where it was before, but I significantly brought it back down to where it peaked at. And if we could teach people how to use their brain to minimize their pain, if they understand that pain is purely a signal, it doesn't mean there's tissue damage or something physically wrong. It could have been at one time, but over time, the tissue heals. And sometimes those patterns are just stuck, and those cycles are stuck in our brain. But if we can take them out of reality with virtual reality or other tools and help them realize you can control this through your brain and you can separate that pain, it changes everything.
Yeah. So exactly. So it turns out, like you were saying, pain is complicated. And if we can understand when it's mostly a mechanical source, like we really can get in there and fix this. We can change the way people move. We can have surgery to fix this, and it's going to make a difference for them. We know how to act. If we recognize it's no longer primarily even about that mechanical source, then we can send them a different way for treatment that's going to help them to fix that pain a different way. Yeah. And that's all that's basically what this is about, is just helping to identify where can people go to receive the best outcome for this very challenging condition.
Yeah. What do the devices look like now? You talked to me about like converting to like clothing, like skin tight clothing. Is that new? Is that where are we at with that?
This is where we're going now, right? So, I described kind of this patch of tape that's on the back that you have on for 15 minutes. That's cool. We're really excited about that. But we'd like this to get more involved in your life, to do the things that you were talking about at the beginning, right? This kind of heads up display, what's going on with my body. In order to do that, we've got to get it embedded in your life so you're comfortable wearing it. And so the version we're working on right now is a compression t-shirt version that just slip it on, undershirt underneath your clothes, and it's just
and there's
basically
a possibility this might be out in the next couple of years, right?
What you're probably more optimistic than me, but
I'm very optimistic. I'm like, let's get this out on the market.
But we're hoping to start like testing this with, some of the, we're looking for opportunities to kind of get a study going where we're using this on real people to make sure it works right, to make sure people are comfortable with it. We're looking to start that study within the next year or two, definitely. That's exactly what we're targeting. And as soon as we're able to start collecting that data, then we can start looking at then how does it work for people? And that's the point at which now it can transition to everyday life.
When do you got to get to a point where it's good enough research, or it's at the level you want it to be where you sell it to the market?
Yeah, so
because BYU owns all of this studies, right? Because it's been happening there.
Yeah, so
essentially, BYU, the institution, would sell it to a distributor or a company that would then make it for anyone that wants to use it.
Yeah, so mostly professors are terrible businessmen. That's kind of business people, right? So the university, what we invent is owned by the university, and then they're looking for people to license it to, and they give a little back to the inventors. It's a nice kind of thing because
hopefully you get something out of it. That's a lot of work. Nice. We're talking like a decade. I mean, how long have you been working on these?
A long time.
Maybe more.
Yeah,
I mean, think about a PhD. That's just a decade and a half in itself.
Yeah, but mostly when you talk to professors, the reason they do stuff has nothing to do with the finances. It's mostly about just like, I want to do something that has an impact. It makes a difference for people. That's kind of where we're at. Like,
and
we really
so many
want that to
people
happen.
don't know that, like, what we know as clinicians and providers comes from science, right? That's something that's measured, the research. Like, I'm so grateful for every research article that comes out that informs my clinical decision making, because if we didn't have research, how do you even make scientific evidence of what we are doing and how it's going to help, right? So we're so deeply appreciative to what you do to get us that data to help us make informed decisions, because really there's three components to evidence-based medicine: the research, clinical expertise, what I've seen developing over years, the patterns that I've recognized, and then the patient preference, right? But without that third piece, we're literally, there's no stability, right? And it gives us science, it changes over time, and sometimes that's frustrating, but at the same time, it's not that the science lied, it's that we just learned more, right? And I love that quote from Brené Brown, like, it's not that science lied, it's that science learned more, and that's what we're striving for, is learning more and more so we can decrease pain, decrease injury, and improve the human experience.
Yeah. And in essence, that's what this tool is about, right? It's about learning more that's going to affect, our understanding. I mean, imagine the day when the way you move is actually like a symptom, right? So you get a little pop-up, instead of taking your temperature in the morning, you're getting a little alert on your watch, says, hey, you're moving different today. Something must be going on. And you realize it has
probably
meaning.
Slept for 4 hours,
Yeah. And it has meaning, and maybe gives you a heads up and says, hey, we think this is probably what's going on with you, and maybe you should do this. Or maybe it's setting you up for a period of low back pain, like a flare, or maybe it's, maybe something is going on that you could adjust, with your.
How funny would it be? It's like, we've recognized every time you walk into your job, the back pain increases. You should probably get another job.
That's right. This clearly makes you, right? This clearly
and
makes
then they
you
show
sad.
Their employer, my app says I need a new job.
My app says that coming to work makes me sad. I should stop.
Yeah, that's what it's all about. So tell me, what are the issues we see with this? I mean, I'm thinking about one right now. The pain neuroscience education for physical therapists is getting super in depth. I am, what am I, 6 years out of school now. We spent a ton of time getting education from psychologists that came in and taught us a whole course on all this. And then there's a huge course on pain neuroscience and fear avoidance, and making sure we understand these principles and we're a part of that team. In psychology, not that we're taking over the psychological role, right? But we're getting people to move. We're helping them understand this is a psychological component, and we're gradually increasing or decreasing the fear avoidance into those positions, right? So is what I'm saying is, how does these things keep up with education, right? And what issues do you see with these devices coming out?
So, that the interesting thing about being an engineer is that most engineers love new tech, right? There's always something new coming out. And it changes the way that we do science all the time to have those. We have just hit this seismic disturbances in the way that we educate with the appearance of ChatGPT and other kind of AI tools that are available now to our students. Causes us to ask the question, what are we adding to this experience now? How is it that we're training? And I think almost all of us in education have been asking these questions. And I think it's really important to differentiate what we as humans add to this versus what a new tool adds, because we add really important things as humans. As a clinician, you're never going to be replaced by a technology that tells you, oh, you just follow this recipe. You have to be part of that process. But if you think that your role is constrained to the diagnosis, and that's what I do, or to this particular aspect of guiding the therapy, you may find that those roles change, right? And the next set of students, getting educated on this in 5 years may have a very different education about how to use new tools that have just come out to do some of the things that right now you're doing in a very different way, right? You're collecting this information with surveys and talking to them and having them move and guiding. And frankly, that may be a 5-minute process with a wearable sensor system that gives you everything that maybe took multiple visits to kind of understand about the people you teach. But your role will evolve, and the role of education is going to evolve in the same way. And I think it's exciting because more data, more tools means that we can do more. Like we can push further, we can help more, we can.
Yeah, I was talking to a civil engineer yesterday. He owns a practice that used to have around 50 engineers. And now he says they get more done than they got done with 50, and now they have 30. He said the technology is become so incredible that we literally almost cut staff in half, but it doesn't replace the human, right? We need humans, but it's making us more efficient humans.
And the question would be like, okay, so they had 50, now they've got 30. And you might think, oh, well, that means there's 20 people out of work, but that's not how it works.
Yeah.
Those 20 civil engineers now are working on another project somewhere. So the world is a better place by having 30 working here busy. And 20 working over
He's
there.
Like, yeah, we're still a month booked out.
And the thing is, like, that's true for us too, right? That means that you can help more people. There's no shortage of people
absolutely
that need, your help.
I remember
here.
In school they told us there was this curve that they were showing us, and I can't remember the exact year. I think it was by 2020, 30, the baby boomers will exceed the amount of healthcare workers. There's this threshold where there'll be more people that need care than actual healthcare providers. So if we don't become more efficient as using these tools and AI and helping speed up the process, what used to take me 30 minutes in analyzing now may take me 5. But it doesn't take out the human component. We're still a part of that, but it helps us be more efficient in analyzing, right? Is that what I'm getting from this?
It's amplifying your ability to help. And that's really the cool part here.
Yeah. So really, the biggest danger that I see is that people try to replace the professional, right? Or the provider. It's like, oh, I'm just going to use ChatGPT to rehab this, or I'm just going to use this app rather than getting professional medical advice on top of it.
Exactly. Right. I mean, and that's exactly the point, is that when you have this explosion of people who need help and there aren't enough providers, that's an issue. Now people are trying on their own to figure out stuff that probably they're going to get it wrong, might hurt themselves. And frankly, people who don't have expertise sometimes step into the gap and bad things can happen too. So, having an ability to amplify your voice to help more people seems like exactly what is needed.
Yeah. I a good example of this is, I think it's a big issue in our medical system. I love transparency with patients, but one of the big issues that I'm noticing is that when you get an MRI, it's uploaded to your medical chart, and then your provider probably doesn't call you for a day or two after. So all of a sudden you have all this medical interpretation from a radiologist that's intended to go to a provider that is then going to interpret for you based on the physical exam, right? But they start reading it on their own. They start AI, ChatGPT, like, what does this mean? And based on studies, we've seen that their pain score goes up 3 points. And why is that? Because they're seeing things on their MRI that probably don't even matter. And there's a psychological component that all of a sudden their pain gets worse because it's verifying, I have pain, it shows 12 things on my MRI, therefore I have cancer, like all these things that they just, that they interpret themselves, which can be very damaging for the patient, So I think that's a great example of making sure we don't use these devices to make our own interpretation, that we use the human to say, okay, some of that matters. The majority of it doesn't. Let me tell you the two things that do matter. Because these radiologists, their job is to explain everything that they see. Degenerative change, great. Everyone has that. It's called aging, right? Like all these different things that they describe in the MRI, most of it doesn't really associate with your symptoms. So it's not that we're saying we don't care about that. It's purely, it's white noise. And most people have those things. Let me tell you the things that matter for you.
That's right. That's one of the major roles of a clinician, right? It's to interpret a large amount of data that's coming at you and to figure out what are the relevant pieces to solve the puzzle. And really, I guess that's what I'm saying is you're about to get inundated with even more massive troves of data. And that same problem of weeding through all this data to figure out how to help the patient is important. Thankfully, there's tools like AI and ML that can help winnow that down a little bit, but they're never going to be able to replace kind of that piece where you go in and you say, okay, let's sort the things that matter from the things that don't.
Yeah.
And getting to the most important messages, really, that's really important and needed.
Well, as we wrap up this conversation, this has been so helpful to understand the future of research and where it's going and how it can help society and solve complex problems. What do you hope that the patient understands about these devices? What do you hope and what change this creates in society as a whole?
Well, I think that what I would like them to know is that more information about them coming in is only going to help. So I think we have this natural resistance, right? I was having this conversation with an insurance agent about like, oh, hey, we could get your rate down if you put on this little device that measures how fast you're going and how you slow. And I'm naturally resistant, right? I don't want to have that in my car. Not because I drive crazy. I think I actually drive pretty well, but because I don't want the violation of my privacy.
I don't want to know the truth.
But in this case, what we're talking about is an opportunity to know yourself better, right? To really just to get to know what things make you tick. And as an engineer, I love that one of those is the way that we move, right? And understanding that
85%, I think it's around 85% of low back pain is mechanical, right?
Yeah.
Is that statistic correct?
Probably not.
Okay.
But for
no,
acute,
it's unspecific. I'm sorry.
Yeah. 85% is non-specific low back pain, meaning we really don't know what's going on.
Yeah. Which is wild, right? For people with low back pain to hear that, like, 85%, we don't know what's going on. Really, we know it's multifactorial, but what is the thing and how do we discover that?
That's right. And that gets to exactly what we're trying to figure out here is in order to uncover that kind of challenge, we need more data. We need to know how you're moving. We need to know all these new pieces. And with those, we can start to peel back the onion and get to the part here that kind of tells us exactly what's going on. It enables better treatment, better data. We get better
more
informed.
Customized treatment. I think about my really tall people. Like, how do those lever arms and the way you lift, how does that add torque to certain areas in your body? You have to probably move, or you have to move differently than someone that's really short, right? They might be able to lift a huge load in this specific movement. You need to be more aware and you need to build up more control through these muscles to be able to do it. So I love how this is more customized and teaching people this is your body.
Maybe I can say it this way. Right now, when we talk about evidence-based medicine, we're talking about using data that's come from clinical trials that have hundreds of people in them, and we're averaging results across those to try to figure out what to do for a person who likely doesn't match any of those averages. But what if you could do a clinical trial where the sample size was exactly one? It was you. And you were the one that was in that clinical trial, and you had massive amounts of data from how you behaved under certain circumstances and certain treatments that you could actually use to inform what should be done for you. And that's what we're talking about here, is a clinical trial.
That's so cool.
Where you are the subject and we know a lot about you and we know how you're going to respond because we've got data about you that helps us to give exactly the right treatment for you.
It's so cool. Well, I'm so excited about this. Anything else you want to add, or where you hope this to go in the future?
My hope is just that it's going to make an impact, that it's going to make a difference, that people are going to have a chance to learn more about themselves. And I guess maybe one piece that I'm really excited about here, I'll diverge just for a little moment.
That's what I like to hear.
Right. So is that I can see the vision of how this works here in the US. It's cool, right? A cheap wearable system that provides massive amounts of data that informs clinical decisions. But there are other places in the world where they don't have access to an MRI, where they don't have access to the same healthcare, where getting to the doctor may take them 8 hours on a bus somewhere. And this kind of technology can be sent to them in the mail. They can pick it up, they can put it on at home, and the data can be sent from their phone to the cloud and give them information right back there and wherever they're living. So this ability to make an impact in low-resource international spots across the world, to me, that's exciting too. To change the paradigm in places that maybe haven't had access to really cutting edge
something
kind
you
of
could replicate
pieces
easily and cheap.
It's exactly the kind of technology that translates across the world.
That's incredible. Well, I'm so excited to see where it goes, especially, I mean, I'm optimistic, but I'm thinking in the next couple of years, at least till we start seeing it come out to market and where people are talking about it. Man, I'm just thinking Iron Man suit. My mind keeps going there. Like, I just think it'd be so incredible for clothing to be able to detect these motions and give us good information. So thank you for what you're doing. You're doing your all your research assistants, your other colleagues that are doing this. Thank you, because it's going to make a very meaningful impact, and what you've done in the past is making an impact. And I appreciate you sharing these conversations and sharing the data for clinicians, because it's so helpful for us to know what's coming out, how it's going to impact the world, and how we can be a part of that as well. So thank you.
Thanks. Pleasure to be here.